We'll have a chance to ask questions at the end. And next, I want to introduce our speaker, Dr. Kathryn Pennington, who's gynecologic oncologist here at Seattle Cancer Care Alliance, performing mini-invasive to complex gynecologic surgery and administering chemotherapy. She also did a lot of training in Michigan and came west to have her faculty practice.
Sorry, I'm just trying to find it.
I'm glad you made it.
Yes, me too.
So let's close it. Save.
There we go.
So here you go. So this is forward, backward. This is a laser pointer.
Great, thank you.
And
All right. All right, thank you everyone for having me. I have no disclosures except that I, like that pharmacist, am crazy about birds. So here are a couple of our pictures that we have. And also a special thanks to Dr. Kathleen Moore at Stevenson Cancer Center in Oklahoma, who let me borrow many of these slides. So my objectives in this talk are to review the most practice-changing and/or exciting presentations from ASCO regarding ovarian, endometrial, and cervix cancer. It's a big task. And I'll also try to let you know a little bit about what's coming, other important studies that are coming. So we'll start with ovarian cancer. So the EWOC-1 trial sought to address how chemotherapy should be adjusted for our elderly or vulnerable patients with a poor performance status. And so a previously validated scale had been the geriatric vulnerability score. You can see here that these are the items that were on it. You got 1 point for each of those that pertain to activities of daily living, instrumental activities of daily living, low albumin, lymphocyte count, depression, anxiety. And so women who were 70 years old or older, as well as with a GVS score of 3 or higher, were eligible for the trial. And they were randomized to Q3-week traditional carboplatin and paclitaxel with an AUC 5 to 6, single-agent carboplatin, or what many of us refer to as the MITO-7 regimen with weekly carbo AUC of 2 and paclitaxel 60 milligrams per meter squared. And on average, people completed 50 to 65% of cycles. And what you can see from this is, so arm B, which was the single-agent carboplatin arm, really underperformed compared to the other two arms, both with respect to PFS and OS. Even for the most vulnerable patients, the ones with a higher GVS score, they saw the same thing, that single-agent carboplatin was significantly worse compared to the MITO-7 or the traditional Q3-week regimen. And so the GVS score shouldn't just replace clinical judgment, and obviously we have to assess whether our patients can tolerate it, but this suggests that really for most of our patients, when possible, we should be giving them a carboplatin and paclitaxel. The next set of studies I'll talk about for ovarian cancer pertain to maintenance therapy. That was a big theme at the meeting, and PARPs in general. And so we know Bevacizumab is approved in the front line as well as in recurrence. And so what about PARP? Why? And then how do we integrate that with our practice? So we know in 2018, Olaparib got approved for first-line maintenance in germline and somatic BRCA mutation carriers. And then I'm going to talk about some of the other trials that are coming. And so currently, Olaparib is the only approved PARP for the frontline maintenance setting. I love summary slides, so you'll see these throughout. And just to briefly review SOLO-1, which got that approval, that was looking at germline or somatic BRCA mutation carriers that were randomized to Olaparib or placebo after a complete or partial response to platinum. And the results were stupendous. They were just astounding in terms of the significantly improved progression-free survival with Olaparib compared to placebo. And health-related quality of life scores were not clinically meaningfully different. And so that led to the approval. So one of the abstracts at ASCO was looking at subgroups in SOLO-1, and do these results hold up? For instance, if they had primary cytoreduction versus interval cytoreduction, and we saw the exact same thing for each subgroup. Similarly with residual disease, no gross residual disease compared to people left with residual disease, we saw the same benefit. Similarly, when they stratified by CR versus PR, we saw the same thing. And the hazard ratio for women with stage 3 upfront surgery, no gross residual, the median PFS has not yet been reached compared to 21.9 months. And so what additional PARP studies are coming? That was in the upfront setting for mutation carriers with BRCA1 and 2. We also know that PARPs may work in tumors with DNA damage repair other than BRCA1, and that up to 50% of tumors may have some sort of homologous repair deficiency. And so there's a lot of interest in looking at whether or not PARP can be included in the frontline setting for other women as well. So Veliparib is the first one that people are looking at. The VELIA trial is coming, and that will be randomizing women to Veliparib with chemo, followed by Veliparib alone, Veliparib with chemo, followed by placebo, or traditional Carboplatin Paclitaxel with no maintenance. And one of the abstracts that was presented was by Dr. Moore, which showed that in a phase 1 study that Veliparib can successfully be added to standard frontline chemo without compromising chemotherapy dose intensity. The PAULA-1 is the next trial to look out for, and that's going to be, again, following CR or PR with frontline chemo, randomizing people to either Olaparib with Bevacizumab maintenance versus Bevacizumab maintenance alone. And then the last trial will be randomizing, this is the PRIMA trial, will be randomizing women to Niraparib maintenance versus placebo. And here is just an overview of the phase 1 frontline maintenance trials that we have, the ones that are completed, and then the 3 that are coming for your reference that summarizes the different patient populations in each. So next we'll move on to maintenance in the recurrent setting. And so we have 3 PARP inhibitors for ovarian cancer that are approved for this indication, Olaparib, Rucaparib, and Niraparib. We all know that in recurrent ovarian cancer, after a response to platinum, that there's efficacy for BRCA Associated tumors with pretty significant magnitude of difference, anywhere from 16 to 21 months versus 5.5 months. It's a really big magnitude of difference. But we're also seeing evidence for efficacy beyond BRCA mutations as well, albeit the benefit is more modest, 4 to 5 months-ish for those groups. And so I'll highlight the NOVA trial in the middle here of Niraparib. In that trial, I'll just remind you that it was women were randomized to Niraparib versus placebo, and they looked at germline mutation carriers, but also non-germline mutation carriers. And they looked at an HRD test by Myriad, My Choice, which did not actually discriminate between responders and non-responders. It appeared that even women that were HRD negative, or tumors, sorry, that were HRD negative, that they still could benefit. And so one of the ASCO slides was pertaining to this theme, which was, can we figure out for women who are not germline mutation carriers who might benefit, or anyone who won't benefit from a PARP maintenance? And so they looked at multiple different homologous recombination repair genes besides BRCA1 and 2. And what they found was actually that HRD, as well as having these homologous recombination mutations, were not good negative biomarkers. They did not predict people who wouldn't respond. They still saw a benefit in all of these subgroups. And so what I take away from this is really that it's that response to repeat platinum that is the best biomarker still. We know that not everyone will respond again when you re-challenge them with platinum, but that's our best biomarker. And so now we'll talk about treatment using monotherapy with PARPs. And we currently have 2 that are approved, Olaparib for 3rd line or greater in germline mutation carriers, and then Rucaparib in 2nd line or greater with germline or somatic mutations. And here is a summary slide of the PARP inhibitor studies we have as treatment, including study 19 for Olaparib, Ariel 2, as well as Quadra, which was Niraparib. And the response rates vary a little bit, of course, because the patient populations also are slightly different. So Solo 3 was an important trial that was presented at ASCO. So this was looking at women with recurrent platinum-sensitive ovarian cancer and a germline BRCA2 mutation, and it compared Olaparib to non-platinum chemotherapy. And I'll highlight that that's non-platinum chemotherapy. That's a little unusual in a platinum-sensitive setting. Most people would give platinum, although we will note that many of these women were pretty heavily pretreated already. About 50% this was going to be their fourth line or greater of chemotherapy. And so it was investigator choice for the non-platinum regimen, liposomal doxorubicin, paclitaxel, gemcitabine, or topotecan, and the primary endpoint was overall response rate. And so the overall response rate for all patients was 72% for Olaparib versus 51% for chemotherapy. When they looked at women who were heavily pretreated, the overall response rate was still quite impressive at 59% compared to 39%, and then it was even higher if you restricted it to women who were less heavily pretreated. And it did show a significantly improved progression-free survival. There was no clinically or statistically significant difference between health-related quality of life between the Olaparib and chemotherapy arms. And there were no new safety signals. MDS did not appear significantly higher. And then fairly similar, actually, in terms of dose reductions, although the Olaparib group tended to have less treatment discontinuations due to adverse events. And so for women with platinum-sensitive cancer who you are not going to retreat with platinum, this suggests that Olaparib can do as well or better than standard chemotherapy. So the next trial I'll talk about is the NOVA-2 trial. And so in this trial, it was platinum-sensitive recurrent ovarian cancer with any number of prior lines of therapy with measurable disease. And they were randomized as treatment to either Niraparib or Niraparib with Bevacizumab. And they stratified by HRD status and chemotherapy-free interval. And the primary endpoint was investigator-assessed PFS in the ITT population. So on average, most patients had either 1 or 2 prior lines of chemotherapy, so a little bit less heavily pretreated. And as you can see, the combination of Niraparib and Bevacizumab had a significantly improved PFS compared to Niraparib alone, with a median PFS of 11.9 months versus 5.5 months. And this was true, again, for all subgroups, the HRD positive, negative, BRCA wild type, and mutated, although I do note the BRCA mutated, it looks like there's a little bit lower magnitude of benefit, perhaps. And overall response rate was 60% with the combination versus 27% with Niraparib alone. Again, quality of life did not look significantly different between the 2 arms. And then the last PARP trial I'll talk about is the CLIO study design. So there are 2 arms of this, and it's the platinum-resistant arm that was reported on. And so that was women who were platinum-resistant. They excluded platinum-refractory. BRCA mutations were allowed, but they did not stratify on them. And they were randomized to either Olaparib monotherapy for treatment or physician's choice treatment. So again, similar to the other design with Solo 3, except this is in the platinum-resistant group. And here's kind of the breakdown of distribution of how many lines of chemotherapy you can see on the right. But again, a pretty heavily pretreated population. Median prior lines in the Olaparib group was 4. Median prior lines in the chemotherapy group was 3. It's important to note when we're interpreting these results that the arms were not balanced and that there were proportionately more BRCA mutation, germline and somatic mutation carriers in the Olaparib group, 21%, and only 3% in the chemotherapy group. So that's really going to skew the results. And there was no difference between Olaparib and standard chemotherapy in progression-free survival. When they looked at separated out BRCA mutations or not, which I think is really important, the numbers are much smaller. In the Olaparib group, the response rate for BRCA mutation carriers was 36%, versus in chemotherapy 0%, although only one patient was in that category, so it's really hard to make meaningful conclusions. And in the wild type group, Olaparib had a 13% response rate compared to 6%. And so this is just adding to the list a summary slide of the new studies that we have. So an important question that's coming up now, we know PARP is getting added into the front line for all mutation carriers, possibly could be added in the future depending on these studies for non-mutation carriers as well. So what happens when these women recur? So if they are successfully retreated with platinum in a recurrence, should we give them another PARP inhibitor as maintenance? Also, if they have a recurrence, should we treat them with PARP monotherapy even though they've already been exposed to a PARP? So just this idea of PARP after PARP, what should we do? And we don't have a lot of data on this yet, but this study presented at ASCO in poster form was a proof of concept study where they collected women who had progressed on PARP inhibitor, and they looked at archival tissue before and then again at baseline when they had been noted to progression, and were then treated with Cediranib and Olaparib. And we do see that there are responses. In the platinum-resistant cohort, they did see 2 responses, partial responses, as well as disease stabilization. And so this just suggests there may be some individuals that can still respond or benefit from PARP after prior PARP. There was also an SGO presentation that suggested similar findings. Again, numbers are very small. And I'll be particularly excited to see they're looking at different mechanisms of resistance, whether it's reversion mutations or other mechanisms of resistance in this group. And then just to look at what else is coming, so the OREO trial is going to look at this very thing with retreating with Olaparib. So basically women who had a prior PARP and then get treated with platinum-based chemotherapy will be randomized to Olaparib maintenance or placebo with PFS as the primary endpoint. So we'll look forward to those results. So next I'll move on to endometrial cancer. So GOG-261 was a very exciting study for uterine and ovarian carcinosarcomas. Mostly, the majority of was the uterine cohort for carcinosarcomas. And as you know, IFOS and Paclitaxel is considered the standard of care regimen. Many of us have already shifted over to giving Carboplatin and Paclitaxel due to a more favorable side effect profile as well as data suggesting similar efficacy. And so this is a randomized trial comparing those 2 arms. The primary endpoint was overall survival. And so you can see in the uterine cohort, which had 449 patients, that there was no difference. So I should back up and say that the null hypothesis was that Carbotaxel was inferior to ifosfataxel, and from this, that was rejected, that it was inferior. And then when they looked at PFS, they could actually say that that also rejected the null hypothesis of inferiority. So in addition, it was actually superior, statistically significant. There were 9 deaths on therapy, 2 possibly due to Carbotaxel. Otherwise, there weren't really any significant differences between PROs, which I was surprised by based on just my own experiences in observing these women. But we can say from this study is that Carbotaxel now is an established standard of care regimen that we can offer to women with carcinosarcoma. There was a lot about immune checkpoint inhibitors as well, as people would expect. And so here are a couple of the abstracts that were presented. One was with durvalumab and one was with avelumab. With durvalumab, they looked, and these were both phase 2 studies. Overall response rate in women who had MMR deficient tumors was 43%, whereas in MMR proficient, it was only 3% response rate. And similar for avelumab, response rate of 26.7% versus 6.3%. So from these studies, it looks like there's reasonable and encouraging activity for MMR deficient tumors, pretty disappointing response for MMR proficient tumors. One of the abstracts also tried to look at predictors of response to avelumab. They did find that there were some that IHC actually seemed to capture the most MMR deficient groups, that there were some cases where next-gen sequencing or PCR actually missed it, and that there was an IHC positive patient that responded. So again, kind of using the best biomarker has yet to be well established. Notably, responses were seen regardless of PD-L1 status, and actually all of the responses were in PD-L1 negative tumors. And then they also tried to assess whether or not high mutational burden was a predictor, and it was not. But they did note that non-responders in the MMR group had a higher number of deletion mutations and association with mutational signature 20. And that they also were able to explain some failures based on loss of function mutations in JAK1, JAK2, and B2M. And so these are things we can look forward to that maybe we will get some better guidance in the future on who to select. The next study was a randomized phase 2 trial of durvalumab plus or minus tremelimumab. And this is the interim analysis, so this is not final results. But again, similar to what we learned in head and neck, the results were disappointing for the combo. The overall response rate thus far was 15% in the durvalumab group, and then in the combo group it was 11%, so it doesn't seem that the tremelimumab is adding much. This was a predominantly MS stable cohort. 86% of the patients in this study were MS stable. And then last, this wasn't presented at ASCO, but I did want to give some contrast. This was presented at our Society of Gynecologic Oncology meeting, looking at dostarlimab, because in contrast to the studies presented at ASCO, this actually did demonstrate clinically meaningful response rates regardless of MSI status, with an overall response rate of 30%. It was almost 50% in the MSI high cohort, but 20% in the MS stable cohort. So I think the jury is still out on that. And here is a summary slide of those findings. I want to highlight this last, sorry about that. This last study there of pembrolizumab and lenvatinib, which was just published in Lancet Oncology this year, because I think that's one that many people don't know about, but had pretty exciting response rates for recurrent endometrial cancer. And so that's something we should use in our toolkit. Again, like 85% of those patients were MMR proficient, or their tumors were. There were only 4 patients that had MMR deficient tumors, and they had 2 out of 4 responded, but again, the numbers are small for that. But that's something we should definitely thinking about for our patients, and we have 2 trials that we can look forward to the results of that are actually comparing pembro with lenvatinib to investigator choice chemotherapy or compared to Carboplatin. All right, last, we'll move on to cervical cancer. So this study was comparing neoadjuvant chemotherapy followed by surgery to traditional chemo-RT in women with cervical squamous or adenocarcinoma or adenosquamous, stage 1B2, 2A greater than 4 centimeters, or 2B. The primary endpoint was overall survival. For women in the neoadjuvant chemotherapy arm, they did not specify what type of chemotherapy, except that it had to be cisplatin-based and at least 225 milligrams per meter squared. A portion of women got cisplatin monotherapy, some got cisplatin and paclitaxel, and some got cisplatin with another drug. And then for the women who underwent surgery, adjuvant radiation therapy was recommended if the tumors had high-risk features, so parametrial involvement, positive lymph nodes, positive margins, per how we would usually manage. And so in this study, looking at the neoadjuvant chemotherapy arm, 23% had a complete response at the time of surgery, and 15% had an optimal response, but 52% had a suboptimal response. And they defined complete as no microscopic residual disease and optimal as carcinoma in situ or stromal invasion less than 3 millimeters. That'd be a pretty significant response. And then 27% of patients got adjuvant treatment afterwards. In the chemo-RT arm, 8% did, and for most patients, that was actually a completion hysterectomy. And so looking at overall survival, there was no statistically significant difference in overall survival between chemo-RT, which is the blue, and neoadjuvant chemotherapy, which followed by surgery, which is the red. The chemo-RT arm was superior with progression-free survival. There was more progression in the neoadjuvant chemotherapy followed by surgery arm, which is not surprising, honestly, and there were definitely patients who never made it to surgery. And so that's pretty similar to a trial that was published in JCO last year, I want to say, which had similar findings of worse progression-free survival with neoadjuvant chemotherapy compared, but no overall survival difference. Lastly, I just put up a slide summarizing the checkpoint inhibitor trials that we have in cervical cancer so far. I want to highlight a few studies that are coming that I'm excited about, that were presented, the concepts were presented at ASCO. So the KEYNOTE-826 trial will be randomizing women with recurrent, persistent, or metastatic cervical cancer that were not previously treated with chemo to either pembrolizumab and chemo versus chemotherapy alone, with primary endpoints of PFS and OS. And then the KAYLA trial will be looking at locally advanced cervix cancer getting chemo-RT alone versus chemo-RT with durvalumab, and I'm excited to see the results of that. The last study in abstract form presented was this study of a single-arm phase 2 study of adoptive cell transfer using autologous tumor-infiltrating lymphocytes. So basically, the patient had a portion of the tumor removed by surgical resection. The tumor was fragmented, and then the TILs were expanded via IL-2, and then infused back into the patient's body after a lymphodepletion regimen. And in this study, again, this is just preliminary finding, but the overall response rate was 44%. So 3 out of 12 patients had a CR, and there was a 78% of patients had a reduction in tumor burden. So that's something that will be going forward in future trials. And thank you for inviting me.